you for the opportunity to come and speak to you today. If you've got any questions, it's hard to know kind of what to talk about, so just stop me and say I don't understand and I'll go through it again. So what I wanted to talk to you about today is what is motor neurone disease, a little bit about the genetics, but then Professor Blair is going to put more detail about that. Then what we're learning more about the link between frontotemporal dementia and motor neurone disease, some of the treatment trials that we've got running, and my area of research, which is looking at the physiological phenotyping. So that means how motor neurone disease affects how our body functions. So when we talk about motor neurone disease, or ALS, which is its other name, what we mean is it's a form of what we call a neurodegenerative disease. So a neurodegenerative, when we talk about neurodegeneration, that's an umbrella term for a number of conditions. So these conditions include things like Alzheimer's disease, frontotemporal dementia, motor neurone disease, and also Parkinson's disease. And what we know more and more is that these conditions are caused by proteins that are abnormally deposited, mainly in the brain, but in motor neurone disease, also in the spinal cord. And they result in a number of symptoms, including changes in behaviour, muscle changes and weakness. What we're learning more and more is these conditions can overlap as well. And so that makes it difficult to diagnose clinically, because often patients can present, for example, with behavioural changes before they develop the symptoms of muscle weakness in motor neurone disease. So when we talk about motor neurone disease, what it is it's a disease of two systems. So it not only affects the brain, but also the spinal cord. And when we diagnose the condition, we're looking for a series of symptoms and also signs. So we talk about both upper motor neurone and lower motor neurone symptoms. So upper motor neurone symptoms are things like someone may present with stiffness, they may present with muscle spasms, they may present with what we call emotional lability. So they may describe, the carer might describe, you know, we're watching something on TV, it's a little bit funny, I laugh, but the patient keeps laughing and laughing. Or we see something sad on the TV and they start crying when they never would have started crying over that. When we see the patient in the clinic, things we're looking for in upper motor neurone changes are what we call spasticity. So patients can become quite stiff. We look for what we call hyperreflexia, so that's when we check the reflexes and we get a big response from the patient. And we also, the more things are more specific down there. We also look for what we call lower motor neurone changes. So that's, patients may describe what we call cramps and also fasciculations. So that's little kind of, they're almost a bit like twitches, but you can see the muscles rippling. That can occur in normal people. So if you've got fasciculations, it doesn't mean you've got motor neurone disease. Sometimes at night time I feel fasciculations in my legs and I start to think, oh, is that normal? But we're looking for a pattern of symptoms together. Also, patients might describe what we call wasting. So if I think we've got a pointer. So if you see here, these are hands of a patient with motor neurone disease, and you see the wasting of what we call the first dorsal interossei. So that's that web space between the first finger and the thumb. They also might have wasting of their limb muscles up here, and also of their shoulder muscles. They can also present with wasting of their leg muscles as well. We also look for tongue wasting as well, and we can also see fasciculations in the tongue, so that's little ripples in the tongue as well. So when we diagnose someone with motor neurone disease, what we're looking for is a pattern of these signs, and your neurologist may refer you for other tests, including what we call neurophysiology, and that's where they stick a needle into the muscles and look for electrical evidence of all these changes to diagnose motor neurone disease. So when we talk about motor neurone disease, again, it's an umbrella term for different types of presentations. So some patients might have what we call spinal onset. So this is when they have weakness. Usually it starts in one arm or one leg. So they have weakness in an arm or a leg, and that progressively spreads to involve either the other arm or the other leg. And often it can stay just on one side, but usually it tends to involve all four limbs. There's a second type, which we call Bulbar Onset, and that's where patients present primarily with swallowing difficulties as the initial symptom, but can also present with speech abnormalities. And then there's a third type called progressive muscular atrophy, where they have shrinkage of the muscles in all four limbs. And then the last type is what we call primary lateral sclerosis. And primary lateral sclerosis tends to be a much slower progression than the other three forms. And these patients tend to just have upper motor neurone signs, so they don't have the lower motor neurone signs that I was talking about. So these patients don't tend to have as much wasting, and they tend to have much more spasticity, so be quite stiff in their movements. One of the aspects that we're learning more and more about motor neurone disease is it just doesn't involve muscle weakness. It involves other symptoms of the body. So we're learning more and more that memory and cognition can be affected, also autonomic function, so temperature regulation, blood pressure control can be affected, and also some patients can present with what we call sensory problems, so they can have numbness involving their hands and feet. So I just wanted to touch briefly on the genetic aspects, but Professor Blair will talk about it more. So we think about 90% of patients have what we call sporadic. So for some reason they develop motor neurone disease. We don't know why. It's probably a combination of their genetic makeup with some environmental factors. In about 10% of patients, they have what we call a familial form of motor neurone disease, and that's usually what we call autosomal dominant. So their grandparent may have had it, then one of their parents have had it, and then they develop it. And often we find a causative gene, and these are all the genes that have been associated with motor neurone disease. And the most common one is this gene called the C9orf72 mutation. And that usually involves families where some family members may have motor neurone disease, some family members may have motor neurone disease and frontotemporal dementia, which I'll talk to you about in a minute, and then some family members just may have frontotemporal dementia. So that kind of leads me into the link that we know that exists between motor neurone disease and frontotemporal dementia. So we know there are a group of patients that will just have motor neurone disease, so they'll just have muscle weakness. But then at the other end of the spectrum, there are patients that will have frontotemporal dementia, so they'll have changes in their behaviour, changes in their memory, and changes in their cognition. And in between, there are patients that will have a mixture of the two. So some patients will start off with frontotemporal dementia, and then they'll go on to develop motor neurone signs. And some patients will start off with motor neurone disease, and then go on to develop changes in their behaviour and cognition. And we think that this arises because we know that the protein that causes motor neurone disease is deposited in the brain. And one hypothesis is that this protein spreads through the brain. And so it usually starts in the motor area for motor neurone disease, and then spreads to the frontal lobes to cause symptoms of changes in behaviour and cognition. And we can see these changes on imaging, and I'll go through a scan of a patient with frontotemporal dementia that explains how they develop the cognitive changes. There is research coming out that shows that the behavioural changes that we see in motor neurone disease are much more common than we actually think. So I see a lot of patients that we diagnose motor neurone disease, and they say, well, at least my memory and my cognition won't be affected. And what we're learning more and more is that in a certain percentage of patients, they will have changes in behaviour and their cognition. And I think it's important to tell people about that, because they can make changes, they can understand why they may be experiencing things and make plans for their future. So this is a study that was done in Ireland, and what they did was they looked at the different stages of motor neurone disease. So stage 1 is very early and stage 4 is very late. And what they did was look at changes in behaviour, including apathy, which is loss of motivation, loss of sympathy, and eating behaviours, disinhibition, which is being a bit inappropriate, talking out of turn, and symptoms of psychosis, which is having thoughts about things that other people may not share with you. And what they found is that these symptoms are present early on in about 20% of patients, so apathy is the most common symptom. And as the disease progresses, patients develop more symptoms of apathy, so they become less motivated. And that's important for carers to understand, because I get a lot of carers coming in saying, as the disease progresses, he just won't do anything, he just wants to sit in a chair, I can't motivate him. And they start to blame the patient, but it's not the patient's fault. It's actually part of the illness that these patients are having trouble in motivating themselves. Also of interest is they develop changes in their eating behaviour. So patients tend to develop a sweet preference as the disease progresses. So I'll talk to you more about that. And when we do cognitive testing as well, what we find is patients have changes in what we call executive function. So that's your ability to plan things, make decisions. They also have changes in memory, which is the grey one, and also language changes as well. So this is a scan of a patient who started off just with muscle weakness. Oh, actually, I think this scan doesn't work, but I'll describe it. The video didn't work, I forgot we checked it. But essentially, it shows a scan, and what he had was shrinkage of the front part of the brain. So even though he started with weakness affecting his limbs, when we looked at his brain, he had shrinkage of the front part of the brain. And that was responsible for his changes in behaviour, changes in memory, and changes in cognition. We've done a lot of studies as well looking at apathy and how that changes one's outcome with ALS, and what we found is that as the patients develop more and more apathy, that tends to have a worse effect on their overall survival. And I think that's important for trying to target treatments that may help with cognition and apathy. So what I wanted to talk to you about now is, so we're in the clinic, what are the treatment goals? So what should you be asking your neurologist to do, and what should you be expecting? And so what I want to talk about here is what disease-modifying treatments we've got, what a multidisciplinary care model is, how we should manage respiratory function, and how we should manage weight. So there is at the moment only what we call one disease-modifying treatment. So a disease-modifying treatment is a treatment that can prolong your survival. And the drug available is riluzole. And traditionally, what the studies have found is that it can improve one's survival from 3 to 6 months, but that's very variable. So in some patients, it may have a better effect than other patients. And how we think it acts is that it may be protective to the underlying neurons and the underlying brain. There is this recent study that suggests that it has its best effect when we start it late in the disease course, but all the other studies, this was a kind of red herring, all the other studies have suggested the best effect for riluzole is starting it early. So as soon as we diagnose someone with motor neurone disease, we start them on riluzole. And a lot of patients will take the tablet and say, it's not doing anything, it's useless, why am I paying this money for this tablet? But what they don't understand, and probably we don't explain properly to them, is that you may not necessarily see a benefit from the tablet. So you won't feel better on it, but without the tablet, we don't know what you'll be like. So it may be, we know it is definitely slowing the progression of the disease and having a benefit to your neurons. So we promote putting everybody with a diagnosis on riluzole. So we know that this study came out of the UK a couple of years ago, and what that shows is that patients who are managed in a multidisciplinary care model actually do better. So what we mean by a multidisciplinary care model is you have your doctor, which is the neurologist, and the patient and family at the centre of the clinic. But also you've got access to things like social worker for services and counselling, psychology, physiotherapy, a gastroenterologist to talk about feeding issues, and also a speech pathologist. And studies have shown that patients who tend to be managed in a multidisciplinary care model do better. But that doesn't mean you have to be, because I realise people who are in country areas, for example, can't have access to those resources. So it's about kind of asking things like ACAT for access to a speech pathologist, access to a physiotherapist, and things like that to make sure you can try and create your own multidisciplinary care model. The next thing I wanted to talk about is respiratory symptoms. So does anyone, I might stop now and ask you if anyone's got any questions at the moment. Yeah.
About Rebekah.
Yeah.
In terms of the measure, what is, when you say 3 to 6 months, what does that mean actually?
So that means 3 to 6 months of survival.
But how is that measured? Is that through, say, measurement of the blood?
No, so that's measured just in, so they look at studies in patients. So when we look at studies, we say, when did the patient have their onset? And then they look at patients when they passed away. And they compare those that had riluzole and didn't have riluzole and look at the number of years that they survive.
Okay. And is there a timeline that you're aware of from research that says that, okay, from the onset, what are the different stages in terms of, say, playing limb? When does the functionality of, say, the limbs cease versus versus, okay, is there an average?
The problem is that we don't agree. So there's different groups use kind of different functional measures, and there's no kind of overall staging for motor neurone disease. In our clinic, we use the ALS-FRS, which is the ALS Functional Rating Scale. And that's probably not great, but it's not bad either. And that looks at things like muscle strength, ability to eat by oneself, looks at respiratory function, looks at ability, to walk and things like that. But the problem is in the research studies, there's no kind of overall staging system, and I think that's one of the things that we're working on at the moment. Yeah.
Dr. You mentioned there's a correlation between motor neuron and the memory loss. Is there a demarcation for somebody who's senior, normal attrition of memory loss?
Yeah, so again, it's kind of looking at the pattern, and I guess one of the misconceptions is that we all lose our memory as we age, which isn't true. So we know that these syndromes of dementia, I see a lot of patients who come and say, oh, I'm just getting old, that's why I've lost my memory, but actually it's a disease process. And so when patients with motor neurone disease, we test their memory and their cognition, and we look at them so we test them every 6 months, and often we can see a decline in their memory over that period. So we'll talk about respiratory symptoms now. So this is often missed. So often patients first develop respiratory symptoms at night time. So they'll have trouble in sleeping, and it's often not noticed until they've got quite severe symptoms. And often respiratory symptoms, if we let them go unmanaged, can lead to a worse prognosis and also a lot of discomfort for the patients. So the symptoms we're looking for someone to suggest they might have respiratory problems is that they have what we call a reduced exercise tolerance, so a reduced ability to do things that they normally do. So if in fit and healthy people, we would measure this by their ability to walk 6 minutes, but that's not appropriate in patients with motor neurone disease. So we're looking at things like, for example, they can't tolerate having a shower like they did previously. They can't tolerate things that exerted them. They have shortness of breath on exertion. They have orthopnea, which means they get short of breath when lying flat. So you might notice people having to use more pillows than they did previously. Often patients who have poor oxygen levels can have a change in their cognition. So you might notice they're not as sharp as previously. They can have what we call paroxysmal nocturnal dyspnea. So this is patients wake up in the middle of the night gasping for air and finding it difficult to breathe. And they also might develop changes in bulbar dysfunction, so that's changes in swallowing. So a change in voice characteristics, increased secretions, poor cough, and problems with swallowing. And it's important to keep an eye out for these symptoms because there are treatments that can help. It's important, if you notice any of these symptoms, to ask your neurologist to refer you to a respiratory doctor who can do respiratory tests and even maybe possibly a sleep study to see if you need further things to help with your oxygenation overnight. So now I wanted to talk about clinical trials, and MND is probably, out of all the neurodegenerative diseases, it's the one at the moment that has the most interest in clinical trials. And I think that's because a lot of money's been raised through the Ice Bucket Challenge and lots of other means to provide money for research. So the current clinical trials that are running in Australia is there's a trial using Tecfidera. And so Tecfidera is an agent that we use in Australia to treat multiple sclerosis. So multiple sclerosis is another neurological condition where patients multiple sclerosis, patients develop weakness, but it's caused by inflammation within the brain. And there is some interest that motor neurone disease may also be an inflammatory condition. So we know that patients who do develop motor neurone disease may have an increased incidence of inflammatory conditions within their family. So when we look at studies, we've got patients who've got an increased incidence of rheumatoid arthritis, lupus, thyroid conditions. So that kind of provides a link that there might be an underlying inflammatory condition that causes motor neurone disease. And so that's the rationale behind trialling Tecfidera for motor neurone disease. And at the moment it's running at 2 sites in Sydney, the Brain and Mind Centre and Westmead Hospital. The second trial that's running at the moment is a trial called Fortitude ALS, and this is using this agent. They're very hard to pronounce, but it's called you can read it, Reldesemivir. I can't pronounce it. But anyway, essentially what this agent is it's kind of like a muscle activator. And what it's trying to do is activate the muscles to see if that affects respiratory function, muscle function, and also overall function. And it's been running in North America, Europe, and now Australia. And I mean, it's 7 study visits over 18 weeks, so it's a shorter study than some of the others. And the last study that's running in Australia is a drug called levosimendan, which essentially we've used this drug a lot in cardiology. So it's well trialled in patients, so it's a safe drug. And essentially what this drug does is it aims to activate calcium channels. So we need calcium channels for our muscles to contract. And this is used commonly in cardiac wards, and so they're trialling it in motor neurone disease to see if it may have an effect on muscle function. So does anyone have any questions after that section? No? Okay. Oh, there's one at the back. So usually there's an email address at the end, so if you just email it and then email any of the sites and then they'll screen you. And then usually what that involves is coming in, being seen in the clinic, and then they work out if all of these trials have kind of strict inclusion-exclusion criteria. But I think it's worthwhile looking at the trials that are available and emailing the people and seeing if you're eligible.
From respiratory tests, some of the questions are related to lung capacity.
Yeah.
Is there a direct correlation between lung capacity, say, going from 64% to 60% or something like that, to lifespan?
Yeah, so we know that essentially as your respiratory function worsens, that's associated with a shorter survival. So that's why it's important to be seen by a respiratory doctor, because we do know that when people have poor respiratory function, we can put them on what we call non-invasive ventilation, which essentially is a mask that they can wear at night. And essentially what that does is it pushes air into the lungs, and that can help with their overall function, help with their shortness of breath, help with their symptomatic management, and also help with their survival.
I would like to know, like you mentioned about the trials, so how would you know which one is the best for you?
So I think I'll give you an email address at the end, but it's just going to, and there's lots of centres around Sydney that run trials. So Macquarie runs trials, the Brain and Mind Centre runs trials, Westmead Hospital, and it's just about contacting them and saying, I'm a patient with motor neurone disease, I'd like to be on a trial. And usually what will happen is they'll get you in and see you, and then they'll work out kind of which trial you might be eligible for. Okay, we'll keep going. So what I wanted to talk to you now is a bit about the research I've been doing. And that's essentially looking at what we call physiological function of patients. And as I mentioned before, motor neurone disease isn't just a disease of muscle weakness, but what we're learning more and more is that things like autonomic function, the eating behaviour and metabolism can be affected, and also sleep can be affected. And what I wanted to talk to you about is the research that we've done in eating and metabolism, and also autonomic function. So when we talk about metabolism, what we mean are things like body weight, insulin levels, cholesterol levels. And what we're taught, I guess, all the time is that having a higher cholesterol level, having a higher insulin level, and being diabetic are bad things. But what we're learning more and more is that particularly in diseases like ALS, having a higher cholesterol can actually improve your prognosis. So this is the kind of thing to kind of eat what you want. And what I wanted to talk to you about is the studies we've done that have shown that. So we started at it from the frontotemporal dementia side of things, and what we found was a lot of patients were saying that the patients were eating a kilogram of sugar a week, they were putting honey on everything, they were obsessed with ice cream from McDonald's. And what we did was we did these studies where we essentially got patients with FTD and compared them to patients with Alzheimer's disease and normal controls, and essentially got them in on the proviso that they were coming for fasted bloods, and then said, now as a natural progression you can have breakfast. And what we did was monitor how much they ate without them knowing. And what we found was the patients with FTD ate almost double what the normal control subjects did. And also we did a second experiment where we made 3 types of dessert. So Eden Mess is an English dessert. And we had 3 different, so that one had 20% sugar, that one had 40% sugar, and that one had 60% sugar. And what we found were the patients with FTD loved the one with 60% sugar, whereas the other groups didn't like the sugary one. And when you talk to doctors of patients with MND, there was a rather cool study they did in the UK where they put lollies on the table in the MND clinic. And what they found was the MND patients tended to eat all the lollies. And I don't know if other carers have also noticed that patients tend to develop a sweet preference as well. Then what we did is look at what areas of the brain were controlling these areas. And what we found is there are these kind of complex brain changes that control these areas involving the frontal lobes and also structures in the brain that control reward. So that got us thinking, we know that there's a link between FTD and motor neurone disease. So are there also these eating changes in motor neurone disease? So we automatically assume that motor neurone disease, because the patients lose weight, they must not be eating. But I think it's much more complex than just not eating. I think the weight loss is probably the result of that the patients are hypermetabolic, so they've got an increased energy expenditure. And that's probably from respiratory problems, but also muscle wastage as well. And what we also know is that in motor neurone disease, patients tend to have a higher cholesterol level. They are also insulin resistant, so there's an increased incidence of diabetes in motor neurone disease. And we've also shown that as the patients develop cognitive changes associated with FTD in motor neurone disease, their weight tends to increase. Also, a lot of patients describe for the first time in their life that they've developed abdominal fat deposition. So their limbs tend to waste, but for the first time they've noticed fat around their abdomen. And all of those changes, so the high cholesterol levels, the insulin resistance, and the increased fat deposition around the abdomen are associated with a better prognosis. So these patients tend to survive longer. So what we wanted to do was look at how eating behaviour may affect survival in ALS. And so what we did to do this is we got patients to fill out surveys that documented how much they ate over the last 6 months and any changes in eating behaviour. And what we found is that, contrary to what we thought, patients with ALS didn't not eat. So they were eating but still losing weight. And that's probably because they've got increased energy expenditure. And as patients develop cognitive change, they get more prominent changes in their eating behaviour. And this eating behaviour is associated with a better prognosis. So the more fat, the more sugary things you eat, the more protein things you eat, the better you'll do, the longer you'll survive. That got us thinking, well, how can this be? And so the next study we did was to look at how what patients eat affects their cholesterol level. And so what we found was that patients who had an increased fat intake that pushed up their cholesterol levels, and actually having a higher cholesterol level improved people's survival by 3 times. And so that means that what we do now for all our patients is take them off their statin therapy. And we let their cholesterols run high. And so I get a lot of letters from particularly patients' cardiologists saying, how can you let the cholesterol level run at 6? You know, that's going to affect the heart. But it's looking about what's the most immediate problem at the moment. And the immediate problem is the motor neurone disease. That's the thing that's going to affect one's survival. The studies for cholesterol affecting your heart function are over 20, 30 years. And so what we do is we take all our patients off statin therapy, and that's been shown to improve survival. The other study that we're doing is, I mentioned about the patients having increased abdominal fat deposition. So I don't have any results as of yet, but what we're doing are these scans called Dexa Scans, and essentially that looks at every ounce of fat that's on your body and tells you where it's located. And the preliminary results suggest that patients have increased abdominal fat around the abdomen, and that's related to their eating behaviour. And studies from overseas have shown that that actually improves one's survival. So I guess the take-home message from all of this is that a lot of people say, oh, I shouldn't be eating fat, I shouldn't be eating sweet things, but I think it's all in moderation. So we encourage our patients to eat as much fat as they can, and also to maintain their body mass index, so not to lose weight. And so all of this research is kind of part of this physiological changes within the body. And the last part I wanted to talk to you about was autonomic function. So we know that motor neurone disease also affects the autonomic nerves. So a lot of patients will describe changes in temperature regulation. So for the first time they notice they're really hot when it's freezing cold outside, or they're really cold when it's hot outside. And they also describe changes in their urinary function and also in their ability to tolerate pain. So a group of patients find that they can tolerate much more pain than they could have previously. And that's because there are changes in this small structure in the brain called the hypothalamus. So this is a study we did in patients with frontotemporal dementia, but we're doing it at the moment in patients with motor neurone disease. And what we found is that they've got changes in all of these areas of autonomic function, and that relates to shrinkage of this tiny structure, the hypothalamus in the brain. And so that's got us thinking about treatments that we might be able to target at the hypothalamus to see how that affects survival. So at the moment, we're doing studies looking at physiological change, including changes in metabolism and sleep, and looking at patients 10 to 15 years. So what we're doing to do this is looking at the genetic forms of motor neurone disease and looking at people that we know have the mutation but haven't developed the disease yet, to see if we might be able to pick up changes early on, because that's probably where treatment will have the best effect, if we can treat people before they develop the symptoms of motor neurone disease. So this is the clinic at the Brain and Mind Centre, and if you just Google it, it will come up with all the contact details as well for the clinical trials. So I think that's all from me, if there are more questions.